You're going to have various structured presentations that will address various topics, specific topics that are listed on your programs. But for the first hour, we have a rather informal hour to talk about whatever the things that you think should be done and are not being done research-wise. Mark, I don't know whether you want to elaborate on that.
No, I think this is an opportunity for us to engage in discussion about the kinds of research that we do, the kinds of research that we would perhaps like to do, the types of research questions that we feel should be addressed, and an opportunity for us to interact with individuals that either A, we don't know, or B, with whom we wouldn't have as much opportunity to interact. So there's no set agenda, we haven't been given a mandate, it's more of a networking kind of an opportunity. And with that in mind, I think it might be good, because I don't know very many people in the room at least, if we just made some introductions and let everyone know who we are, where we are from, the kinds of research questions we either engage in ourselves or have interest in engaging, so we get to know each other a little better. And while that's going on, I'd like to send around this yellow pad, and if you could please print your name so I can read it, and perhaps provide your email address if you wish. Then we have a way not only of knowing who is here, but communicating with each other should we desire to do that in the future. So while we're giving the introductions, I'll just start this pad. And since I'm already speaking, I'll start with myself. My name is Mark Ott. I'm in the Department of Anesthesiology and Pain Medicine at the University of Washington. I just moved there about 3 years ago from the University of Michigan. I'm the Vice Chair for Basic Research in my department, so I get to deal with tasks that focus on building research infrastructure as a basic scientist in a clinical department. And of course, during these days, especially with government shutdowns and reductions in NIH funding, it can be very challenging to try and build research programs in this climate. My research and my lab focus primarily on the relationship between sleep and immune function. I have an interest in sepsis and a lot of ongoing projects that focus on relationships between sleep and sepsis in the aging brain, what that means to blood-brain barrier permeability, and questions like that. We also have projects that are now started and for which we're hoping to obtain funding on mild TBI and sleep. So we're focused on animal models that have a neuroinflammatory component but are relevant to what the physicians in my department see in the clinical environment every day. And with that, I think I'll stop. I think everyone knows Mervyn, but in case we don't.
I'm Mervyn Mays, and I'm at UCSF. And I've been there for 4 years. Prior to that, I was at Imperial College, prior to that at Stanford. My interests over the years have been the mechanisms of action of sedative hypnotic agents, principally alpha-2 agonists. And more recently, in trying to understand cognitive decline post-operatively, we're interested in the aseptic trauma-induced neuroinflammation and in the perioperative period, and its effect on a bunch of things, including cognition and sleep. So that's who I am, David.
I'm sorry, I've just walked in. We're introducing ourselves.
Yes.
And with a very brief description of what you do.
Right. David Hillman. I'm from Perth, Australia. I'm a latter-day anaesthesiologist and now spend my whole life in sleep medicine. My main interest, I think, from the research point of view, is the upper airway physiology, so mechanisms of collapsibility. I'm very interested in the transitions from consciousness to unconsciousness, both in sleep and anaesthesia.
Please introduce yourself.
Yeah, okay.
If you stand up and face the audience, it might be easier.
I'm Watanaito from Japan, University, Tokyo University, and I'm in anesthesiology. I'm mainly interested in the relationship between about neurophysiology and anesthesia.
My name is Bob Carney, and I run the sleep center at Salt Lake City, Utah. We have a fellowship training program, and my main interest has been in a lot of interest in sleep medicine, but more recently opioids and sleep medicine. But I've been in sleep medicine mostly on a pulmonologist background.
So I'm Frances Chung. I'm an anesthesiologist at the University of Toronto. And my research is actually in screening and identifications of sleep apnea patients in anesthesia. I do have a passion to bring the sleep medicine people and also anesthesiologists together to interact.
I'm Ryan Nations. I'm a nurse anesthetist for the Navy. I'm also a doctoral student at the University of San Diego. I'm very interested in the screening and indications of OSA in the third trimester of pregnancy.
In the third trimester of pregnancy?
Yes.
Okay.
Right when anesthesia gets involved.
Okay.
Dr. James Oak from Chardon, Ohio, Belize. But I'm in a small community hospital, but we do a number of things that I think patients at risk. PCA pumps, we do epidural narcotics, orthopedics, and bariatric surgery. So my biggest concern, and I think so important, is the question of monitoring for post-op respiratory depression on the floors. And the issue, I think, is with the technology that now is becoming available, what impact that should have on detecting respiratory depression, and whether that should become mandatory. We played around with a drug called Depadur, and I don't know if it's still on the market, but it was an extended release epidural morphine. It was almost diagnostic of sleep apnea. And patients who didn't have it, we wouldn't use it on patients we knew had sleep apnea, but on patients we thought maybe had it, it was almost diagnostic. And for the sake of excellent nursing, we were able to detect some of these events, but I think it's just real important to really focus on monitoring post-op. So thank you. Thanks.
Hello, I'm Mary Chisholm. I'm an anesthesiologist at the Hospital for Special Surgery in New York. And I just have an interest in OSA as it's become more and more prevalent. And actually, establishment students just encouraged me to come to this meeting and said it would be a great exposure to the research that's going on.
Hi, I'm Harvey Organic. I'm the medical director of a sleep center in the Metro Detroit area with a background in pulmonary medicine, and I've had a long-standing interest by way of training in the neuromuscular control of breathing and ventilatory control of breathing as it relates to respiratory disease, and which is the way I got into sleep medicine originally 30 years ago.
I'm Susie Karen. I'm a anesthesiologist at the University of Rochester, New York. I'm not in Minnesota, so I'm less famous Rochester as I tell people before. My main hat is actually in education. I'm the vice chair for education in my department. I've been a little all over the place in my research with obstructive sleep apnea. I still did start off with control of breathing research with Dr. Ward, and then got into upper airway collapsibility. And I'm interested in kind of the whole perioperative study, but I have a lab that's kind of dormant right now because I've got a lot of clinical and educational responsibilities. So I'm set up to study the interaction of sleep information. I've got neurophysiologists who are willing to work with me to use EEG measures. I can study upper airway collapsibility. I'm set up to do that. I have a lot of equipment. I don't have a lot of time, and I'm looking for projects to get involved with.
Okay. A lab as a launch pad. Bill?
I'm Bob Agamotesi from University of Chicago, pulmonary critical care and sleep. Should I say something else?
Just a brief description of a headline of what you do.
Oh, so I'm in the same boat. I have some administrative duties in terms of running the sleep fellowship program there, directing the sleep lab, clinical sleep lab, and I work as an intensivist in the ICU, but my passion lies in clinical sleep research. I'm interested in obesity hypoventilation. A couple of years ago, because of Francis and David, I got interested in sleep and anesthesia, and I also have interest in diabetes and metabolic implications of sleep disorder breathing.
Just got an R1.
Lucky.
So in that field, you know, you got the RO1.
In sleep and diabetes.
Actually, I also got an RO1 on metabolic syndrome and trauma and cognition. So maybe they pay attention to it.
Oh, you're talking about Suzanne Pratt?
No. Phil.
I am Phil Kurian from UCSF. I'm a recent graduate and anesthesiologist. I'm also a postdoctoral fellow looking at mirroring models in basic science research of circadian disruption and natural rhythm of sleep and the way that they affect inflammation. And more broadly interested in just anesthesia and sleep and the inflammatory profiles that those two states create.
I'm Gunja Panila-Kanta, from the Ronald Reagan UCLA Medical Center. Currently, I'm mostly dealing with the ambulatory patients, surgical patients, anesthesiologist as a profession, obviously. I'm kind of interested with the obstructive sleep apnea patients. I'm always interested. I have noted that some of these patients don't require as much anesthetic, and I'm never sure whether that's because we don't give enough narcotics to them because we're afraid of their breathing, or is that because they just don't require much of anesthetic. Never been able to really study that, and maybe I can get some information from, or some ideas how to go about doing this.
Joe Malhotra, just recently went to the University of California, San Diego. I know a lot about sports, I know a little bit about sleep apnea, a little bit about critical care. Primarily human research, some more basic stuff.
I'm Matthias Eichelmann, and I'm interested in perioperative muscle function, skeletal muscle function, respiratory muscle function, and German trained, as you can tell from my accent. 10 years ago, Atul hired me over to work at the Brigham in his lab in West Germany.
My fault.
I see, that's where it all started, huh?
Yeah.
I'm Jim Nelson. I'm an anesthesiologist from Seattle area. I live in Bellevue, but I work in Tacoma. I'm just a clinical anesthesiologist. I don't do a lot of research. I have to say I've seen a dramatic increase or prevalence in the amount of patients I take care of with sleep apnea issues. And so I want to learn more about especially the basic science because I'd like to be able to give some presentations back at my facility and get the rest of our group kind of a little more aware of it beyond just, yeah, we see this, so what do we do with it? So we have a better sense of that. Our surgeons are just now kind of taking on the issues of sleep apnea, except for ENT. We're kind of aware of it as far as kind of one approach to it. And so I think we're at a point we could actually coordinate with them developing a sleep apnea evaluation or treatment protocol that could apply to the patients that come through, because so many of our folks now that don't know they have sleep apnea that we find down in the recovery room or on the way into the OR sometimes, that we really need to screen better and get a better sense of the management, certainly for the immediate and hope for longer term. Also, I have a unique perspective in sleep apnea or sleep-related disorders. My wife's a pulmonologist by training, but she's done clinical sleep medicine for almost 12 years. So let's just say I hear all the developments that come through the line and what works and what doesn't. So it's an interesting perspective that I can bring from my own personal experience to our works.
Who's your wife?
What's that?
Who's your wife?
Dr. Teresa Jacobs. She has a clinic up in Bell Red area. Not academic, but let's just say where the rubber meets the road in actual patient care.
My name is Richard Warner. I'm a physiologist, PhD scientist in the Department of Medicine at the University of Toronto and also Department of Physiology. The research we do is mechanisms of sleep regulation in the brain, and more recently how mechanisms of sedation and mechanisms of anesthetic action and how those three states cause respiratory depression. And the last few years, we've been very interested in creating a very fertile environment to collaborate, to innovate in new scientific directions. And I led 2 programs, successfully competed for funding into one of them. We have a CHR, Canadian Institutes of Health Research, Research and Training Grant, Sleep and Biological Rhythms, and the aim of this is to create collaborative projects that didn't exist before. So this is not just to support ongoing operating grants, it's really we invite applications, and we've had several in the anesthetic field to bridge projects that they wouldn't otherwise do in their labs. And in fact, one of the great successes we had last year that Francis was also involved in, we leveraged some funds from that grant and got significant investment from our Department of Medicine and also the Faculty of Medicine, plus the Departments of Anesthesia, Physiology, Pediatrics, some other stakeholders, including the Institute of Safe Medication Practices Canada. And we've launched now, as of this summer, a new collaborative, University of Toronto collaborative program in sleep, sedation, and anesthetic sciences, which is very much linked, of course, to the aims and mission of this society. So this is something that we'll be really working towards populating in the next 2 or 3 years.
So what I heard was a combination of clinical investigation, or interested in applying clinical investigation, and some fairly basic stuff. And I wonder if we could ask the basic people first, what do they think is ready for translation? Where in their lab is there work that they think can come to the fore and is ready at least for first time in man or something like that? Anybody want to kick off and say where they think something is getting ready? It doesn't have to be given to man tomorrow, but because after all, I guess we want to ask questions that have an application at the basic level, and I'd like to hear what that may be.
I'll offer one, because
Okay.
I've said too much. So for me, as a basic scientist who's always been in medical departments, I kind of always feel this link to understanding the clinical problem. So for me, the most tangible, foreseeable objective, and I think it's realistic, but the time frame is very hard to pin down, would be what do you do with the information if you know how it is that sleep depresses upper airway muscle function, which I think we do know now. If you know how it is that opioids depress breathing, which I think we're quite close to knowing how that works now, talk about some of that tomorrow, then I think there are rational strategies to reactivate breathing when it's depressed or failing, either in sleep or in the anesthetic state, in combination with therapy to keep either the upper airway open or to trick the cells that are depressed to keep rhythm going in the presence of opioid drugs. So that's what I will.
So Matthias, you got some stuff that you want to share with us about what that could be? In this realm?
So in terms of increasing or restoring ventricular drive, I think 2 concepts I do recommend. One is to give respiratory stimulants. We just finished a volunteer trial where we put healthy volunteers under anesthesia and measured airway collapsibility, airway muscle activity, which of course goes down and collapsibility increases, and we restored it with carbon dioxide. And so that is one question: can we apply that to patients with sleep apnea? It's not a new idea. Mervyn told me that the VA, it's
How long ago VA used to have CO2 on its anesthesia machine. Who remembers CO2 on the anesthesia machines? Okay, okay, so there you are.
So I think maybe not in future in the at the anesthesia machine, but maybe in the recovery room. Maybe we just put no longer just oxygen tanks on, but combined oxygen and carbon dioxide. So that would be one thing. And another vision of my team is to reverse anesthesia. We have a new compound that binds to specific anesthetics, such as ketamine. And wouldn't it be nice if we could really encapsulate our medications? In anesthesia, many of us know there is Sugamadex, is a drug that encapsulates rocuronium, that soon will also be available in the US, so we can extend that concept to other drugs that we use in anesthesia. For opioids, it's a little bit more tricky because you don't want to totally encapsulate them and take them out. So, but these are the two ideas that I go for.
Those are some great ideas. I remember an agent we used to use when I was in medical school called doxapram or Dopram, and people used to use that as saying, oh, this is helpful to bringing the breathing back. That kind of went obsolete. For some reason, people didn't really like it. We were looking at sleep apnea then. That's one thing that I don't know if could be re-evaluated or if it's available. The other thing, I've heard some studies about ketamine, even during the course of the procedure, seems to be helpful in maintaining upper airway reflexes and anatomy, even if somebody's asleep. I don't know if the studies have really shown on that. I just think I heard on one of the audio tapes or audio digests like that. And if there could be more studies in that endeavor.
Yeah. So, I mean, anybody want to comment about strategies for improving upper airway collapsibility during anesthesia other than getting rid of the anesthetic?
Yeah.
Can I add that I think we focused initially on drugs, which I think is understandable.
Right.
Why
is it understandable?
Well, because these are drug-induced states.
Okay.
Yes.
But I think in the sleep apnea field, I think there's a recognition now that there's two things which are happening. One is that the recognition that people end up with sleep apnea for a variety of physiological reasons that may be different between people. And that there's an interest in having devices which are able to not only deliver CPAP, for example, but these are equipped with sensors which can detect airflow changes and perhaps through algorithms that can be developed to be diagnostic as well and respond to a patient's needs as they develop. And I could perceive that the same may be true in anesthetic medicine, certainly in the perioperative setting, which is becoming quite an interesting area judged by recent editorials, where it might be possible to improve people's performance or function post-operatively, but also at other times, simply by having a development and evolution of machinery which are much more clever and auto-adjusting than they currently are.
Yeah, so we're at the back there. Let's see if we can get...
I feel like there's a toolbox that's available to sleep docs for people, and then it's got, variable compliance with patients for the long term, but in the short term, in the post-operative period, perhaps for a couple of days, there'd be improved compliance, and then if we had a different set of tools that would be useful, not just the CPAP machine, but, there's these ProVent stickers to wear on the nose that maybe people wouldn't want to wear for a month, but for the short term. And looking at a bunch of these tools, everybody looks different, everybody's got a different reason for their possibility, and there might be surgical contraindications, but if there's like a mechanical toolbox that a post-operative physician could use that could be studied in kind of a global way until we come up with the off button for anesthesia, which I know we're working
The
on.
off button, okay. Did you want to say something? I thought your motion.
Support what Richard said. I think the key may be to defining the underlying mechanism and trying to treat that accordingly. And so there's a paper that's probably going to get accepted in the journal, looks like on hypoglossal nerve stimulation, for example. That might be something hard to do in the long term in terms of treatment because it's an operation requiring a lot of risk and expense, but something you potentially could do briefly in the post-operative period through a transcutaneous approach, for example. Or there's other sorts of splits of various kinds of perhaps uncomfortable or unsightly, but for a day or two or for an hour or two after an operation may well be reasonable. Other things like these voluntary stimulants are likely to benefit some patients, potentially be deleterious for others depending on the mechanism underlying it. If it's simply activating upper airway motor tone, that's probably a good thing. If it's leading to instability in ventilatory control or increasing drive that can contribute to worsening airway mechanics, that may well be deleterious. So it might be a matter of looking at underlying mechanism or thinking about underlying mechanisms or applying a one-size-fits-all type of approach.
So are we close to discriminating between those patients that require one strategy versus another?
The short answer is no. We can do it in the lab, and it takes several days of either an MD or PhD to be awake for 2 or 3 nights to define all these mechanisms. But we're working on ways of automating it so that we can look at more rudimentary breathing patterns and see what we come up with. Scott Sands is a guy some of you guys know is an engineer in my lab who's very good with sort of signal processing and things. He's working on looking at subtle changes in breathing, trying to identify some of these characteristics.
Yeah.
At the real risk of embarrassing myself by stating the obvious, we're talking about, I think the big problem is post-operatively, not during anesthesia. It's afterwards, the second, third day, that the real problem is worrisome. And there's lots of devices and lots of things we can do, but the simple thing that we can do is get people off of their backs. And we have, in the hospital, they are mandated to be on their backs by the shapes of the beds and so forth. And we have tremendous amount of experience with people who have been mostly outpatients, but some inpatients, unsuccessfully treated with CPAP, very high levels, 20 plus centimeters of water pressure, oxygen levels of 10 liters per minute simultaneously, and unable to effectively keep the airway open until we basically just got them on their back. And sometimes, off of their back, I'm sorry. And in some cases, using a full face mask, I think, may actually induce upper airway obstruction, and it's a very common device to be used. But it's so well known, everybody on the planet knows, I think, that if you sleep on your back, you're more likely to snore and have this, but we totally ignore that in the hospital. And I think if there was a much more vigorous effort at focusing on why people are sleeping on their backs in the hospital, I think it would be a huge difference. You can reduce the effective CPAP necessary, you can improve oxygenation. It doesn't require anything special. Well, it requires some mechanism of keeping them on their back.
Yeah, I have a mechanism.
And
I have a wife that kicks me.
I don't know how many of them there are, but you couldn't probably provide her enough. But but I do think that that's an area that we've actually had some interest in developing some device and so forth for dealing with that. But it's an incredibly simple solution, and there are many complicated cases that we can actually get some people off of CPAP by getting them off of their back. And it's stated in the literature over and over again, this is mainly mild to moderate sleep apnea. I'm talking about in people who have severe sleep apnea on high levels of CPAP and oxygen that are apparently refractory to therapy. Patients that we've discussed in case conference where, we maybe need to do tracheostomy. We don't need to do that. We can just get them off of their back. And we have CPAP failures during titrations in the laboratory, and they're typically on the back until you get them, and having difficulty titrating them until you get them off of their back. So I think this is such a ridiculously simple thing, but I think it's, even though it's known, it seems to be an ignored option.
Well, it may sound ridiculously simple, but if you talk to the intensivists who be trying to treat ventilator-associated pneumonias and the strategies that they're pretty simple strategies, and they seem to work. Well, they change the way that you permissive ventilation. It's a whole bunch of things that are very straightforward but work. And there's you can comment on that, can't you, about how they came about?
Yeah, so 2 or 3 comments along those lines. Then I want to hear David Hillman's comments about your comment, because I think he's done some insightful work in that area. But yeah, in the ARDS literature, there's a randomized trial published in the New England Journal a few months ago on prone positioning, where ventilating people in the prone position was quite helpful in terms of mortality benefit, going from about 32% mortality to about 16% mortality, which is one of the bigger effects we've ever seen in that disease. One of the purported mechanisms reported by the French is improvement in drainage and things from the posterior dependent lung zones, preventing pneumonia and whatnot. There's also some literature on elevating the head of the bed just as a measure to reduce ventilator-associated pneumonia that probably also works. Interestingly, in this week's Blue Journal, there's some papers coming out talking about how some people with body posture have deleterious effects on their respiratory mechanics, either their lung or chest wall gets stiffer for whatever reason. Kind of counterintuitive, but an interesting anecdote. But I wanted to hear David Hellman's comments about the anesthetic state of the lateral posture.
I think it's a little bit simplistic to suggest that all sleep apnea, about 20% of sleep apnea is postural dependent, as defined by an apnea-hypopnea index twice or more that on the back and on the side, and certainly positional therapies are useful for those patients. The problem has been for sleep at least, is that patients find their ways to defeat those sorts of therapies. Although there's some quite neat things available now, mercury switches on neck braces with an alarm and vibratory function, and train people on this. So I think there's something in, there's definitely something in it. Of course, the other thing that strikes me in all of this is that sleep apnea, upper airway obstruction, is not simply about transmural pressure gradients in the neck. Also, there's a lung volume component to it, which is pretty important. So low lung volumes are the enemy here because put simplistically, perhaps a loss of longitudinal traction on the upper airway mediated through mediastinal tension. And so obesity and sleep apnea is not simply about fat necks, it's also about low lung volumes. So I think posturing, head-up postures, for instance, have got an advantage there. So I think there's more to posturing than just on the side. There's also head-up, but posture is the whole answer. We've certainly, Atul and I were involved in some studies some years ago looking at phrenic stimulation as a treatment for sleep apnea. It has some promise. It's tonic phrenic stimulation.
Just a simple comment. I think that it would be probably better if we could just get people to sleep standing up. That would improve the upper airway as well as lung volume.
Yeah, I'm not quite sure how it works in weightless environments. Well,
there's one study that shows that they have decreased sleep apnea.
Yeah, you would imagine so.
Well, it's amazing that the astronauts had sleep apnea.
Richard made an interesting, used the phrase earlier, he talked about the knowledge we have of neurophysiology and neuropharmacology and reactivating breathing. I'm having a fascinating experience with some patients at the moment now who have idiopathic hypersomnia, which is a nasty condition out on one pole of the narcolepsy spectrum. But these people spend the day many hours asleep, and their wakefulness is very low quality wakefulness. And these guys, there's been the suggestion flumazenol is useful for them. We've been using subcutaneous flumazenol with remarkable but not sustained effect. Remarkable.
Flumazenol.
Flumazenol.
Yeah. So, as far as the positioning goes, so we have just finished a study on the OB floor, where we know that patients following delivery are also at high risk of sleep disordered breathing, which we confirmed. And then we did a crossover design where they slept half of the night supine and half of the night 45 degrees elevated. And also it showed a significant decrease in the severity of sleep apnea, perhaps expectedly. So I think I would totally agree with you that it's probably an underutilized strategy, the positioning in specific collectives of patients that are vulnerable to sleep apnea.
There is some data, I can't remember from the journal that I've never seen before, I think it was a death journal or something, but just rotating the head actually changed the geometry of the upper airway. So it isn't necessarily true that you have to be lateral, but even any obliqueness or rotation of the upper airway changes the AP lateral dimensions of the
We've certainly looked at neck flexion, neck extension. It is a remarkable effect under anaesthesia. So from neck extension to neck flexion, about a 30-degree change in angulation changes a critical closing pressure in the upper airway by a factor of about 12 centimetres of water on average, which is a huge effect. So certainly posture is not just about laterality, it's also about neck flexion extension. So on your back, neck flexed is a bad combination of circumstances. And a good example of that is I routinely ask patients with prospective sleep apnea, do they have choking episodes, momentary choking episodes aroused from those. And a lot of patients will tell me the only circumstance under which they do it is actually when they're sitting up and their head rolls forward. Yeah. So neck flexion is another postural modification worth thinking about. And of course, jaw thrust. I mean, the anaesthetists know that the jaw thrust maneuver used in sleep.
And the Smith
with
position,
impulses.
yeah, so those are the things
Mm.
that I learned as a first year anesthesia resident.
Mm.
Snip position,
Yep.
and get the green gas into the right hole. Okay. What about other basic research that looks close to prime time? Something that we can translate from a preclinical into clinical?
Can I ask a question
Yes.
on this? I was excited about some of the ampakine work that was coming out of Edmonton. I think Richard was doing some. Ampakines?
Ampakines, okay.
Richard has done some work with that, but I was excited about it a couple of years ago, and it seems to, at least I'm not hearing as much about it, so maybe you can help us understand what the translation of that is.
Well, the only thing I know is that, so the work, the basic science behind that, some of the work has been done by John Greer at the University of Alberta, who I know well, so that's my only link there. But I
Are you still in your lab as well, or no?
No, we decided that we would pursue how opioids, how are they causing respiratory depression? That was our fundamental question, rather than how ampakines are efficacious or not in reversing it, because other people are doing that.
Can you just give the group one sense about that? I don't know that much about it, but it was something that looked really promising a few years ago. I thought we'd be doing translational work.
Well, there are trials ongoing, as far as I know. And the first one that's been published was, a paper was published, I think, a couple of years ago, showing that it was beneficial in.
When you say yes, what do you?
So ampakines are drugs. So this is why they're called ampakines. Just make sure we're all on the same page. So the idea is that there are certain cells in the brainstem that generate the rhythmicity of breathing, and then they drive rhythmicity elsewhere. So the whole network becomes rhythmic and has an respiratory drive. But the key element is that respiratory drive is transmitted to cells, and in particular, it's been well demonstrated for motor neurons, particularly that drive the upper airway, through glutamate. Glutamate acts on multiple receptor types, but there's a certain receptor type that's involved, is the AMPA receptor. And ampakines are classes of drugs that were initially discovered because they boost cognition, learning and memory. But because glutamate acting on AMPA receptors drives the motor activation of the respiratory network, particularly to the upper airway. What they do is they keep the if I remember correctly, the AMPA receptor open longer, prevent it desensitizing, and hence ampakines are thought to be beneficial for breathing. And it so happens in a variety of preclinical models, be it from slices of tissue versus to spinal column with brain attached, through in vivo animals who are then anesthetized or given high doses of opioids or other drugs. You can reinstate breathing at times when it's very depressed, or otherwise the animal's in apnea and would die otherwise. So these are very encouraging drugs from a very basic science point of view, that if they're taken in combination with opioids, and so you get the preservation of analgesia, which is key. So the difficulty with it seems that pain sensation and the mechanisms by which opioids suppress breathing could be so inescapably intertwined, you'll never separate them. So one of the ideas is we have to understand the mechanism before we can make that statement, so we think we know a lot more about that now. So if you target a mechanism that's separate from that, you can then maybe kickstart breathing and keep analgesia. So as far as I know, in basic science models, including much more in vivo models, including rats, but also swine models, and also now preliminary phase 1 trials in humans, these ampakines are able to stimulate breathing but keep analgesia. So I think that's where it's at.
So who has a basic science discovery that is ready for prime time? Mark, what about you? You've got your neuroinflammation work at
Well, I think in my field it's a little bit tough, because a lot of what we do in our sepsis research, for example, we had a high-profile paper come out a few months ago in PNAS, basically suggesting that mouse models of sepsis, TBI, and burn are useless because they don't translate to the human condition. So now we're in damage control there. And as you can imagine,
it didn't only hurt you, it hurt other people.
Yeah, not just us, of course. So I'm not sure about that, but I think one of the areas that has been of some interest to me in speaking with the physicians in my department really focus on attempts to change the culture. Because it seems like there are it seems as if they're relatively simple and straightforward things that could be changed in the perioperative setting that have high face validity for being of benefit to patients. But they focus on the culture in the clinical setting. Simple things like changing the environment in which the patients are housed. Reduce the lights, reduce the noise, reduce intrusion, maximize the amount of sleep they get rather than fragment their sleep. So these are cultural things that on the surface of it should be relatively straightforward and simple to address. But in practicality, can be very difficult to change in that setting.
So your interest is in the environmental effects on postoperative sleep and try to improve sleep hygiene.
Right. So I'll show you and give just a brief overview in my presentation later. But if we have data that demonstrate that disrupted sleep or fragmented sleep is immunosuppressive and bad in many different respects. So the converse then should follow that improving sleep continuity or sleep quality should facilitate recovery. You know, this is what we would expect to believe. So if that follows, what are the simple things that we can do to improve sleep in the perioperative setting? Well, you're not going to change a lot with medical practice. You're not going to be able to do much in the way of fundamentally altering, medications that are used or surgical manipulations or surgical procedures. But there is this class of factors that seems like it would be easy to address. Turn off the light switch, turn down the volume on the alarms, those kinds of things. So I think from my perspective as a non-physician, those are low-hanging fruit. And everybody says, and there are many publications that demonstrate how completely disrupted and screwed up sleep is in the clinical setting. You see it, you work in those environments. So it just seems a relatively simple thing to address. And I think there's a lot of room for improvement there with minimal effort in terms of drug development or these types of activities that can be very time labor
I wouldn't
intensive.
even go through the physicians on this one. I'd go straight to the nursing.
Nursing
staff.
is a
and
good chart.
yeah.
And?
But
So this is actually an interesting point that you raised because a couple of investigators that I work with at the University of Chicago have tested this. And it's quite interesting because they measured noise levels at different parts of the hospital. And I'm embarrassed to say that certain areas were almost as loud as a barking dog or almost a jackhammer.
I'll show you a slide that
Yeah,
demonstrates
so-
it's worse than that.
So we asked, so when the patients were surveyed, and let's forget perioperative, all patients were hospitalized. When they were surveyed, what was the noise, what was the source of disruption? You would think these would be things that you have no control over, but it's, number one was staff talking. Then it was alarms. Then it was, beeping stuff, pagers and cell phones that the nurses have. And another big one was vital signs.
Yeah.
So they actually looked at interruption of timing of vital signs and risk of rapid response team activation. So there is no question that sleep, and then they measured duration of sleep and quality of sleep by using actigraphy. So sleep is quite disrupted and short in the hospital, which begs the question when people's adherence with CPAP in the perioperative period is 3 or 4 hours, maybe it's not because they're not adherent, maybe that's all the sleep they're getting. So it's that question.
Just want to bring a little bit of a circadian perspective to it. So, sleep is both a homeostatic drive and a circadian drive. There's a growing body of evidence to suggest that anesthesia itself is interfering with circadian rhythm, particular proteins in these clocks and things, and that basically, we think that has metabolic implications, inflammatory implications as well. So some low-hanging fruit, again, clinically would be to do things that would restore those circadian rhythms to people. So one of those less popular suggestions would be timing of the surgery or the anesthetic itself. But then easier things would be maybe trying to abolish the temperature nadir that happens during the surgical or the anesthetic itself, and or the timing of your bolus feeding after a meal. So those are all really powerful sort of Zeitgeibers that retrain the clock, and we distort them unknowingly during our anesthetic and perioperative period.
So if I understand, we're going to maintain the temperatures intraoperatively, okay? We're going to try and get the anesthesia surgery to be done exclusively at night.
Cheeseman's work in bees would suggest that that's the case.
Okay, but let's continue. What else could we do?
So another very powerful Zeitgeiber is, Cliff Saper's done some work on this, but basically food after a prolonged period of starvation resets the clock better than light itself. So they've been using it in jet lag. It's sort of playing around with it in jet lag.
So big deal immediately after surgery.
So, I mean, well, it
Right
depends on...
before surgery, because it helps the anesthetic.
Yeah, exactly. But timing that may be important in recovery of these parameters. So just some maybe thinking about it a little bit more instead of giving your patient crackers immediately or whatever when they hit the floor and they're ready to eat. Timing that better can help with recovery from...
And I think, I'm sure people in this audience remember the CREST study where they woke up the patients during the daytime in order to reestablish their day-night, or at least interrupt the sedation that they were receiving for ventilation. And that had a profound effect on outcome, did it not?
That was actually from University of Chicago. Yeah, J.P. Kress had a paper in the New England Journal.
Yeah, that's
2000, I think, were dailies.
So that's not that. I think he realized that there was a problem here that we needed to reset, and I think there was a pretty profound intervention that has, I don't know, any place that doesn't have a wake-up routine in their in the ICU sedation now. I think it's standard practice.
But to Mark's point, even in University of Chicago where that protocol was done, it took a long time to get embraced. The low-lying fruit was ignored for quite some time.
Implementation scientists tell us it takes 17 years for a well-established intervention to be widely employed. So that's frightening. We went to a patient and said, we know that there's been a discovery 50 years ago, but we still haven't put it into practice. You can imagine another industry, an airline industry, that's saying something like that. So that would be pretty scary.
These cultural changes are almost impossible to implement, and I would confirm what Atul said. I met recently with Pete Morris and J.P. Kress, and we talked about barriers to early mobilization, and then they said, even now, when their week of ICU shift is over, early mobilization concept, is off as well. So it's just, this paradigm of in doubt being on the safe side in the ICU, which means patient is in full synchrony with the ventilator, deeply sedated, and safe. Yeah, it's so challenging to overcome. And if we move on and even decrease the intensity of monitoring, which we need to do if we don't want to wake up during nighttime, this is going to be another cultural change, which is even more challenging than stopping the sedation or mobilizing them early when they're awake.
I know it's a low-hanging fruit to kind of do all this. It sounds, very tempting. But if we had like $1 billion, we could prevent respiratory complications by just telemetrically monitoring everybody overnight with capnography and just call it a day. I mean, we just can't do that. But if we had an exorbitant amount of money and we can just monitor everybody's ventilation like we do in the OR,
why does it require exorbitant amount of money?
I don't know why are we doing it?
The light box, which won't measure ventilation but does measure oxygenation,
And we're too late.
Pardon me?
We're usually too late if we're on the oxygenation.
No, I did say that it measures something other than what we really want to measure. Nonetheless, this is an engineering problem. It's not a biological problem. It's an engineering problem. And if there was sufficient, with all engineering problems, if there's sufficient demand, it will get solved. So like you, I think that some way of measuring ventilation accurately is really required, and we just don't have that here. In fact,
I want to make a quick comment about something that was mentioned earlier about using full face masks and stuff and people being supine. We use CPAP all the time with patients and they're supine, and I find that if you have a nasal mask and I use the full face mask, and it's training the RTs who don't really have any training with using the nasal mask, and the problem of nasal constriction, obstruction, I think that would go a long ways in helping some of these people. Just a quick comment.
And I think I would appeal to the sleep physicians to invent something better than CPAP. Make it easier.
That's another engineering principle. So
even the sleep doctors agree.
We're rapidly segueing into the formal presentation part of the program.
I have a question for you.
Okay.
Yeah. So we've talked about this before, but I'm interested in your thoughts about whether sleep and sedation are the same thing, because I thought there was some
well, I guess it depends on the sedative. That's where I come down and say that there are some sedatives that converge very nicely onto sleep pathways. Perhaps not, absolutely, but quite closely. And there are some that they're very antithesis of sleep and are just chemical immobilizers. And I would put benzodiazepines in that category as one of the, I think it's a superb drug for epilepsy, perhaps anxiety, but boy, it doesn't, I don't see a whole lot of benefit you get from benzodiazepines in the perioperative period.
I was going to make one
Ralph,
comment on
you
that.
want to say anything about that?
Well, I agree with you. I think the search for identity, with all due respect, is a fool's errand. And I think you said it very correctly. I think there are similarities in traits, but they're two distinctly different states.
One of my colleagues did a study at the University of Chicago.
Avery.
You've seen that?
Yeah.
Yeah, so it was published in Sleep, and we were there when these studies were done, 24 hours or 48 hours of polysomnography, and we could not recognize sleep. It's just the waveforms were bizarre.
Yeah.
They look like slow wave sleep, but they're kind of interacting with you, and they're on a whole host of drugs. REM sleep is basically gone for days and days in the ICU.
Yeah, I think REM is really hard to find. It's break very easily. I think we're going to, unless somebody's got a burning comment to make, I think we can segue perhaps. Atul, are you the first speaker? You are?
Yes. Yes.
Then
we're trying to get him loaded on the laptop.
There's some technology problems. Keep talking.
For those of you who were here for the previous discussion and did not yet give us your name and your email so we can use this as part of the networking practice, here's the piece of paper. If you weren't here for the session but you want to become part of this networking session, you can sign anyway.
I have a question for the group, who's also trying to kill time here. You mentioned earlier today the paper in New England Journal of Medicine looking at long-term neurocognitive function in patients who had delirium.
Yes.
Why is there long-term deterioration? So the finding is patients who are delirious when they're sick have long-term neurocognitive decline.
Right. Okay. So just for those that don't know the paper, this is the paper that came out of Vanderbilt, published in New England Journal of Medicine last week, from Pratik Pan, Harry Pandey, and Wes Ely. And what they did is they followed patients who developed delirium in their ICUs. They were either medical ICU or surgical ICU patients. So obviously they included post-operative patients. And what they found, just the observation, was that they followed these patients out to a year, and well over 40% of them that were not lost to follow-up. So these were who were followed up for a year, and they were quite assiduous in following them up. They found that a high percentage, and I'm thinking in the 30 to 40% range, had severe enough cognitive impairment that they could be misdiagnosed as having either traumatic brain injury or early Alzheimer's. That's how severe that mental impairment was. So, okay, so you're asking why. And so there are a couple of reasons that I think you could, if we can extrapolate possibly from Mark's work and perhaps from my work, that there is a neuroinflammation that occurs that should resolve. It really should resolve, but it doesn't resolve. There's something that continues to drive it, or where the resolution mechanisms have completely failed. So either the provocative factors are still there, or the resolving factors are absent, and the inflammation continues. Because inflammation alone can do this. You can induce neurodegeneration of inflammation alone. So that's a possibility.
So there's also this evidence that the ApoE epsilon 4, that gene that's abnormal in both dementia and delirium, is it a common genetic thing, or is it actual causal association?
No, I don't think that in the original cognitive dysfunction studies, the ApoE was not, the alleles was not found to be associated with a high incidence. In the original ones, there are papers in cardiac surgery. After cardiac surgery, the cognitive decline that occurs after cardiac surgery, there was an association in the malignancy, but not in the original ISPSC studies. Yeah.
Is there discussion or consideration of an alteration or upregulation of certain GABA receptor subtypes, which has been shown? This might be an interesting link to the animal literature, because there is some evidence in animal literature that exposure to, even a single exposure to anesthetic can change the regulation of certain extrasynaptic GABA receptors, shown in the hippocampus for days, and this is associated with impaired memory.
Yeah, I think those of us who came into anesthesia perhaps in the 70s, as I did, have a somewhat Pollyannish view, or grew up with a somewhat Pollyannish view of what anesthetics were about, and they sort of flitted into the body and did their magic thing, and then just left the body in the same pristine state that it found it. Well, nothing could be further from the truth. You know, to induce such a profound behavioral change and expect there not to be a fingerprint left behind is just remarkably optimistic. And so I think the possibility of there being long-term changes induced by anesthetics, I think, is quite realistic, and unfortunately is probably the case in the neonatal situation, where in the immature brain it seems that this becomes a real problem when you give anesthetics at a vulnerable time, because there's a long-lasting effect. So I think it's quite likely that anesthetics do have a long-lasting effect, and that could contribute to it.
Maybe a footprint.
Well, this is a footprint. Fingerprint or footprint?
Footprint.
Bigger than fingerprint.
So this is a research opportunity to measure, to find out what these things might be, and measure them.
Yeah, and again, those people who have been in the field of mechanisms of anesthetic action are constantly changing their targets. I think the thing that they're most interested in right now, not so much the molecular species, but the sort of the connectome, how the connectome changes and how the various nuclei from one to another speak to one another, and how that's changed in a sort of a long-term way. So, are we getting closer?
I think we're ready.